Thank you, madam, for that introduction. And so you have completed um, the opioid sessions, but not methadone. So we are going to cover uh, methadone today. Okay. So many of you might have heard about methadone, but I'm not sure how many of you are using methadone. Uh, so it is important for us to understand the pharmacology of methadone because it is the pharmacology is entirely different from other opioids. Methadone is available in India as of now, and it is available from since 2018 for use as an analgesic. But many of you might know that methadone is also used for some other purpose. It is used also. Also for the purpose of oral substitution therapy for psychological dependence with other opioids. And whenever somebody speaks about methadone, many of them, or at least you might have heard, there are many problems with methadone. It can cause this, that, and so it should not be used. So we would be comparing what are the advantages of using methadone and what are the disadvantages of using methadone. So that will give you a clear picture whether we should use it or not, and how we can safely administer methadone by monitoring certain parameters. And another issue which many participants, uh, after finishing the class on methadone and what they are telling us, they were unable to find out a suitable patient to start a patient on methadone. So we'll be talking about uh, what are the groups of patients for whom we can start methadone. And most importantly, how we can convert an opioid to methadone. So there are many conversion methods. Okay. So I am taking you through a patient story. So this is a 30-year-old woman who is diagnosed with Ewing sarcoma in the year 2016, and she received radiotherapy and chemotherapy for the same. But in 2018, she was complaining of pain on the back and legs. Uh, so the oncologist advised her to do an MRI, and it showed that the disease is progressing and there is extension to S1 vertebral body with compression of L5 and S1 nerve root. The PET scan showed pleural metastasis. So this is the pain pattern. You can see the pain starting at the low back, which goes down to the right leg, mainly on the back of right leg. So she described it as a burning type of pain as well as shooting type, and she gets some relief when lies down, but it has increased with any movements, so that patient's mobility is restricted. She actually, this is a patient, real patient story. So she was living in the upper floor of a house, and she was literally in the bed uh, because of this pain. Because any movement will cause severe pain, so she's unable to move, and you know that because of severe pain she would also be unable to sleep. She's angry with everybody else in the house. She's not eating. So there are many issues connected with the severe pain. So the pain score which are shown here is the pain at rest. So these are the medications. So before going on to this, what would you, if this patient comes to you, how are you going to manage a patient with severe back pain which radiates to right leg? How do you manage this patient's pain? You can unmute and speak, or you can type it in the chat box. I can see there are some answers. Neuropathic pain, neuropathic drugs, pregabalin, amitriptyline, morphine. Yeah. So, Dr. Gauri, why do you say you can use neuropathic pain medications?
Uh, because the pain is radiating, sir. Probably neuropathic pain. Maybe that's right.
Yeah, that's correct. From the description and from the distribution of the pain and from the history, you can see there is a having sarcoma. Now it has spread into S1 vertebral body, which is compressing the L5 and S1 root. So all those descriptions, the quality of pain, it is shooting and biting. So all those descriptions fits very well into the features of neuropathic pain. So this patient was getting treatment from another a palliative care physician, and this was the medication she was getting. As many of you talked about morphine, she is already on morphine, 10 milligram Q for and SOS, amitriptyline 75 milligram HS, pregabalin 150 milligram BD, and dexamethasone. But with this medication, there is no pain relief. So now, how do you move forward? So we have neuropathic pain medications here, amitriptyline, pregabalin, and even dexamethasone, thinking that there would be compression of nerves, and morphine 10 milligram, but there is no pain relief. Yeah, titrate the doses of morphine. Yes, that's one possibility. But I want to mention that here the patient developed the toxicities of morphine with 10 milligram of morphine. Yeah, palliative radiotherapy. Uh, okay, palliative radiotherapy to the spine, nerve block. Okay, what type of nerve block? If palliative radiotherapy is going to give pain relief, that will take some time, isn't it? Yeah, the patient is suffering from severe pain for the last few weeks. Okay. Any anesthetist in the group? What would they do?
Sir, any epidural injections?
Yeah, epidural injection. Yeah. So here, the treating physician was an anesthetist, and he did an epidural catheterization and provided local anesthetic infusion along with morphine. And initially, patient had some pain relief, but that was not satisfactory. But even that pain relief was very important for the patient because she was suffering from pain for the last few weeks. And as you know, this epidural catheter cannot be kept there for a long time. So this anesthetist they reinserted the epidural catheter at different sites and managed to keep the epidural catheter for almost 2 months. But then, as I told you, as the time went on, the pain relief which she had initially, that also weaned off. So there was no pain relief, and they are unable to keep the epidural. That was not giving her pain relief anymore. So the anesthetist removed the epidural and started on oral morphine. This time with 20 milligram of morphine for hourly and SOS. Okay. And then gradually titrated up to 40 milligram for hourly and SOS. Again added amitriptyline and pregabalin. But no satisfactory pain relief. Again, patient had delirium and myoclonus, which indicates that you would not be able to increase the dose of morphine further. So, what are you going to do now? How do you manage the pain of this patient? So the patient was on epidural catheter for almost 2 months with a local anesthetic as well as morphine, which was not giving any pain relief. But then removed the epidural catheter and put her on morphine with amitriptyline and pregabalin. Then she developed toxicities of morphine. So how are you going to manage pain of this patient? Yes, Dr. Adira says oral methadone. So, Dr. Adira, can you tell us why would you use oral methadone in this patient?
So it is a neuropathic pain which is not relieved by using morphine or epidural injections. And she also developed the there is and that is the effect of morphine is there. That is, she developed some adverse effect for morphine. So usually these are the indication for starting oral methadone.
Okay, thank you, Adira. Wonderful. Yeah. So this patient, this is the time when this patient approached us, and we thought of starting this patient on methadone. Okay. So when we thought of starting her on methadone, we understood that there are many methods to convert her from morphine to methadone. So if you look at the articles, these are the methods that was available. 3 day switch, rapid conversion stop and go method, ad libitum stop and go method, German model, outpatient titration. So all these were the methods to convert from an opioid to methadone. But there is no literature suggesting which method should we use because there is no advantage of one over the other. But many people were using 3 day switch, and in 2018, as I told you, that was the time oral methadone was available in India, and there is nobody from India who knows how to start a patient on methadone, how to titrate, etc. Because that is a new medication in the Indian market. But there were a few classes which we got from other foreign people, how to convert a patient from opioid to from an opioid to methadone. So they were using 3 day switching method. So but before you convert a patient from from an opioid to oral methadone, you should know how or what is the equianalgesic potency of methadone compared to morphine? So just want to ask, what is the potency of tramadol compared to morphine? Potency of tramadol? I can see Dr. Shruti says 1 by 10th. Yeah, 1 by 10th. So suppose a patient is on 100 milligram of tramadol. What would be the equivalent dose of morphine you need to start? Yeah, 10 milligram. Suppose it is 400 milligram of tramadol. What is the equivalent dose of morphine? It is 40. So, what will be the dose of morphine? The potency is same, isn't it? It is 1 by 10. But here, in case of methadone, you can see depending on the dose of methadone, the potency, depending on the dose of morphine, the potency of methadone varies. So you can see, I'm not going to read this, but understand this is not a linear conversion method. This was the method which many people have used previously. So this patient was on 40 milligram of morphine every 4 hours. So she was taking total 240 milligram of morphine. So just see this 240 milligram. If the patient is taking 240 milligram, that means she is taking morphine between 100 to 299 milligram. So the potency is 8:1. So you have to divide 240 divided by 8. That is 30 milligram of methadone. So that is the dose of methadone that we need to start. But when you convert a patient from an opioid to another opioid, you would get a calculated dose. That is, here it is 30 milligram. But you need not start this 30 milligram completely, because there is something called as incomplete cross tolerance. So the equivalent dose need not be started. You can reduce the dose by 30%, because there are some interaction that is going to happen at the receptor level. So that is for accounting for incomplete cross tolerance, you can reduce 30%. So that would come to 30% of 30 milligram is 9 milligram. So that total, sorry, anybody is speaking?
I think it's somebody is not muted, Sunil. That's all. It's not, if I'm not wrong, because that's what it's some parallel conversation I heard. Is that right? Or anybody?
Yes, ma'am.
Yes. So go ahead.
So,
Sangeet, if you can unmute if someone is not muted, please look into that.
so the total dose of methadone, it is 30 minus 9, it is 21 milligram. That's the dose of methadone you need to start for this patient. So as I told you, if we are going to select 3-day switch method, which is the method many people were using very commonly. So we will take 3 days to convert this 21 milligram. So it would be like this. So on the day 1, you give only 1/3 of the methadone. So you have calculated 21 milligram. So 1/3 would be 7 milligram. But at the same time, you have to reduce the morphine by 1/3. So she was getting 240 milligram. Now you have to reduce it by to 160 milligram. On day 2, you have to add another 1/3 of methadone. That is 7 plus 7, 14 milligram, and reduce the morphine by another 1/3. So it would come to 80 milligram. Day 3, you have to add another 1/3. So by day 3, we will be converting the opioid into complete dose of methadone. So that 21 milligram was the calculated dose. So on the day 3, we will give 21 milligram, and day 3, we will stop morphine. So this is known as 3-day switch method. But here you can see this is what we did. So on day 1, we gave 2.5 milligram of methadone, TID, that is 7.5 milligram, and we reduced the morphine by 1/3, that is 25 milligram for hourly and SOS. So after 3 days, we called the patient. So she was telling that she was able to sleep, and there is a little bit of pain relief. We did not convert or we did not add another 1/3 on the day 2nd. Instead, you can see that we waited till day 7 to convert or to add another 1/3 of methadone. So on day 7, we added another 1/3 of methadone. So that is 5 milligram TID, and we reduced the morphine by another 1/3. And when she had improved pain relief with 5 milligram of TID morphine, TID methadone. And on day 14, we gave full dose of methadone, that is 7.5 milligram TID, and stopped morphine and made it SOS. So on day 14, actually this patient came to our OPD by walking. So this patient, who was literally on the bed on the first floor of a house, who was unable to move, on day 14, she came to us by walking to the OPD. So that was the type of pain relief she had. So what is the reason for this excellent pain relief? Why did she get such good pain relief? So for this, we need to understand little bit of pharmacology. Okay. So methadone is an isomer of S-methadone and R-methadone. And what is the action on the receptors, opioid receptors? It acts on all the opioid receptors, mu, kappa, and delta. Whereas morphine, fentanyl, all those acts on mu receptors. But here, it acts on all the receptors as agonist. Okay. And you know that there are certain opioids which can act as antagonist at some opioid receptors like pentazocine. But here it acts as an agonist on all opioid receptors. Then it also acts like NMDA antagonist. What is NMDA antagonist?
N-methyl D-aspartate.
Yeah, N-methyl D-aspartate receptor antagonist. And which is the usual medication which people use as NMDA antagonist? Yeah, ketamine. So methadone can act like an NMDA antagonist. That is N-methyl D-aspartate receptor antagonist. Then it inhibits the reuptake of noradrenaline and serotonin. So which other group of medication has this property of serotonin and noradrenaline reuptake inhibition? SNRI, yeah. Yes. Serotonin noradrenaline reuptake inhibitors. Name a few medications. Yeah, duloxetine, amitriptyline, all those medications, isn't it? Yeah, even though amitriptyline, nortriptyline, imipramine are all as tricyclic antidepressants, but it acts as a or it inhibits the reuptake of noradrenaline and serotonin. In addition, there are some other mechanisms also. So methadone has 3 mechanisms of action. It acts as an opioid receptor agonist on all the opioid receptors. It acts as an NMDA antagonist, and it also acts like a tricyclic antidepressant. There is another action. It acts on a human either a GOGO related gene channel. Okay. HERG gene channel, which by which it causes HERG blockade, which can lead on to tossed apart and sudden death. So the first three mechanisms are beneficial effects of methadone, but the last one is a fatal side effect. So what are the actions of methadone due to opioid receptor agonism? So as all of you know that when an opioid acts on opioid receptors, it can produce physiological action. So here it acts on all the opioid receptors by which it can provide analgesic effect. But at the same time, it can also produce the side effects, including our constipation, nausea, vomiting, all those things. So we told that it also acts as an NMDA antagonist. So here you can see 4 patients who are on different doses of morphine equivalents. Patient A is getting almost 12,000 milligram of morphine equivalent, whereas patient D is getting about 2,000 milligram of morphine equivalent. What is tolerance? Anybody please unmute and speak. What is tolerance? Nobody?
Pain threshold is increased. Not
Drug insensitivity. Yeah. Can you make it more clear? Giving an example.
Pain relief tapers off. It reaches a plateau.
Yeah. Yes. Dr. Shruti says maximum dose that can be given without any adverse effect. I will give you an example. Suppose a patient is taking 5 milligram of morphine and patient has good pain relief. But after 1 week, the patient says her pain is more. So you are increasing the dose of morphine. Now it reaches to 10 milligram. And now the pain relief, it's same as previous. But after some time, you need to increase the dose of morphine to get the same pain relief. So to get the same effect, you have to increase the dose of the medication. Okay, so that is tolerance. Probably all the, so have you seen any patients on such high doses of morphine equivalents? 12,000 milligram of morphine. What is the maximum dose of morphine you have given to a patient? $20 milligram for our day. Yeah. Anybody else? The maximum dose which I have used in my clinical practice is for 50 milligram 4 hourly. So why some patients require this much high doses of morphine? Probably it is because of tolerance. Okay. So, this 4 patients, all of them are started on 30 milligram of methadone, regardless of the dose of morphine. Everybody was started on 30 milligram of methadone, and all these patients got good pain relief. That means the NMDA receptors are involved in the formation of tolerance. So actually, if you start a patient on methadone, you can actually prevent and reverse the tolerance. Okay. So that's what we have to understand from this patient story. So here we have a patient, 50-year-old woman, who is diagnosed with carcinoma of the breast, underwent modified radical mastectomy, radiotherapy, and chemotherapy. Now she has local recurrence and is complaining of severe pain on the chest, which is radiating to left arm. She is on tramadol 100 milligram every 6 hourly and amitriptyline 100 milligram HS. She is also receiving fluoxetine 20 milligram BD. She presents to you with agitation, anxiety, restlessness, disorientation, diaphoresis, hyperthermia, tachycardia, nausea, vomiting, and tremor. On examination, there is muscle rigidity, hyperreflexia, myoclonus, dilated pupil, ocular clonus. What is the diagnosis? You can guess. No idea? Tramadol toxicity, opioid toxicity. Okay, anything else? This is not a very common diagnosis, but it is important for us to understand this.
Malignant hyperthermia.
This is serotonin syndrome. Okay. So here you can see this patient is how many drugs which can actually inhibit the reuptake of serotonin. Which all medications in this can prevent or inhibit the reuptake of serotonin?
Fluoxetine.
Fluoxetine, yes. I can see fluoxetine and amitriptyline. Dr. Gavri says fluoxetine and amitriptyline. Yeah. What is the mechanism of action of tramadol? Tramadol has a dual mechanism. One is that it acts just like any other opioid receptors. It is a mu receptor agonist, but it also inhibits the reuptake of noradrenaline and serotonin. Okay, so tramadol has dual mechanism. So tramadol, amitriptyline, and fluoxetine, all of them inhibits the reuptake of serotonin. So this is where patients can get something called serotonin syndrome. And if you administer methadone along with some of the medication, there is high chance of getting serotonin syndrome. So these are, you can see, these are the medications which have high risk and the medium risk with these medications and low risk with these medications. So you can see fluoxetine, it has high risk. Amitriptyline has medium risk. And how do you recognize serotonin syndrome? So there are many signs and symptoms by which you can diagnose serotonin syndrome, but it is always our what we know about serotonin syndrome. If you know about serotonin syndrome, only then you will diagnose serotonin syndrome. So the patient can have cognitive changes, autonomic instability, neuromuscular changes. You can see the patient might be agitated. There can be hyperthermia, tremor, ataxia, clonus, cogwheel rigidity, seizures, etc. So if a patient is on methadone And if you are co-administering any other medications which can prevent the reuptake of serotonin, and they present with hyperthermia, agitation, tremor, then think of whether it is due to serotonin syndrome. So this is a rare condition, but this can occur. So if you diagnose it correctly, then it would be, we can treat them. So it's a 70-year-old man. He is taking methadone, 100 milligram for the last 2 months. And he is having carcinoma of the buccal mucosa and is taking treatment. But now he is admitted with fever and breathlessness. And on investigation, he is found to have urinary tract infection. He was given injection ciprofloxacin, 200 milligram IV BD. And as this patient was restless, he was given haloperidol to control the agitation. And then this patient started complaining of another problem, palpitation and syncope. So the physician ordered for an ECG, and it looks like this. What is the diagnosis? Yeah, it's torsade points. So, why did this patient develop torsade points? So, as I told you earlier, methadone blocks the human either a GOGO related gene channel, and HRG HRG gene channels you can see in all the smooth muscles, but it is abundant in myocardium. So when methadone blocks the HRG gene channel, it increases the QT interval, which can lead on to torsade points. Okay. But whenever you read about methadone, you might you would be hearing more about torsade points and increased QT interval. So it is important for us to understand about this study, which was conducted by MD Anderson Cancer Center. They selected 100 cancer patients, and they did a baseline ECG, and then after 2 weeks, 4 weeks, and 8 weeks. So all these patients were started on methadone for pain relief. You can see the median methadone dose was 23 milligram. The range is from 3 to 90 milligram, but most of them is below 50 milligram of methadone. And what they found was, so during their follow-up period in 2 weeks, 4 weeks, and 8 weeks, there were no patients who had any torsade points or ventricular fibrillation. So this is one study which says if you use methadone at a lower dose, the chance of producing torsade points is very, very less. And the dose of methadone which we need to use for pain relief is probably less than 50 milligram per day. But we also know that it is not only methadone which can cause increased QT interval. There are many other medications itself can cause increase in QT interval and torsade points. But if you give methadone along with these medications, there are so many medications, and it would be impossible for you to remember this. So, but just see, these are the medications which we use commonly in palliative care. You can see the azithromycin, clarithromycin, erythromycin, ciprofloxacin, levofloxacin. So all the fluoroquinolones, then macrolide antibiotics, SSRIs, antipsychotics like haloperidol, then fluconazole, ondansetron. So these are medications which we use very commonly in palliative care for treating the symptoms. So be careful when you prescribe any medication if the patient is on methadone, because that can have some interaction with methadone. So moving on to pharmacokinetics of methadone, it is absorbed orally, and it is also available as in injections. But in India, we have only oral formulation. The bioavailability of methadone ranges from 36 to 100%. What are the routes through which we can administer morphine? Yes, oral, IV, subcutaneous, rectal, sublingual. Okay, so actually, the least preferred route is sublingual. It is usually not advisable to give morphine sublingually because we don't know. It is going to take such long time. We don't know how long it is going to take. So it is not usually advisable to give morphine sublingually. But in case of methadone, it can also be administered sublingually. Okay. So what happens after oral administration of methadone? So you can see after oral administration, it will be seen in the blood for almost 2 to 4 hours. And after this, it will immediately disappears into the tissue binding sites. So you can see the administered methadone is going into the tissue binding sites. And you can see now the tissue binding sites are saturated. So once this tissue binding sites are saturated, then the methadone will be liberated into the blood. So in a patient for whom we are starting methadone for the first time, this is what is going to happen. So the tissue binding sites need to get saturated, and this will take at least 5 to 7 days in normal healthy individuals. But if patient is elderly or if the patient has liver failure, it can take up to 14 days, up to 2 weeks. So unlike morphine, where we can actually increase the dose of morphine every 24 hours. But in case of methadone, you should wait at least for 5 to 7 days before increasing the dose of methadone. So this is very, very important because it is not like morphine. Morphine you can increase every 24 hours. But in case of methadone, you have to wait for at least 5 to 7 days because this tissue binding sites need to be saturated, and then only the free drug which is liberated into the blood would be giving pain relief. So this is one of the most important points. So methadone is metabolized in the liver, and you can see there are many cytochrome P enzymes are involved. Cytochrome 2, B6, D6, C7, C19, and many other cytochromes. So what is the importance or what is the significance of this? We know that there are many other medications which is also metabolized by the same cytochrome P enzymes. So if they are given together along with methadone, there can be drug interactions. So this can alter the concentration of methadone in the blood. So either it can increase the blood level or it can decrease the blood level of methadone. So this we should be very careful. So just giving you a few examples of cytochrome P inhibitors. So grapefruit juice, grapefruit, okay. Protease inhibitors. What are protease inhibitors? Examples? protease inhibitors examples. So these are antiretroviral medications. Okay. Then cyclosporin, macrolide antibiotics. So erythromycin, clarithromycin, azithromycin, all those medications, macrolides, amiodarone, non-hydropyridine calcium channel blockers like diltiazem and verapamil. So all these medications are cytochrome P inhibitors. They inhibit the cytochrome P so that the blood level of methadone would be more. So in this patient, if we are starting these medications, actually the recommendation is to reduce the methadone by 1/3. And there are some, these are not the exclusive list. There are many other medications which can be cytochrome P inhibitors as well as cytochrome P inducers. I will show you later. So cytochrome P inducers like phenytoin, phenobarbital, oxcarbazepine, rifampicin, carbamazepine, St. John's wort, all these can reduce the dose of methadone. So what would be the net effect if you give cytochrome P inducers along with methadone? What can happen? Anybody?
Sir, decreased effect of methadone.
Sorry, I couldn't hear Dr. Pratibha.
Sir, the effects of methadone will be decreased.
Yeah, effect of methadone would be decreased. So there would be reduced analgesia. And even that can lead to withdrawal symptoms, isn't it? Because suddenly the blood level of methadone is decreasing. So that can sometimes produce withdrawal symptom. So just see, these are the medications which can either decrease or increase the methadone levels. So again, these are the medications which we use very commonly in palliative care. So if you are going to start a patient on methadone, it would be better to keep a printout of this interactions as well as QT prolongation medication so that it would be easy for you to go through that before you start a patient on methadone. Okay. So another important thing which we need to understand about methadone is excretion. Methadone is excreted through bowel. So a little bit of excretion also happens through urine. But this is supposed to be a safe opioid for patients who has chronic kidney disease. And we say that morphine gets accumulated in patients with the chronic kidney disease. But here, methadone can be safely used in patients with renal failure. What is the duration of action of methadone? It is 8 to 12 hours. So you need to give only twice or thrice per day. But in case of morphine, we know that it is 4 hours, isn't it? And these are the appropriate candidates, or these type of patients should be selected for starting on methadone. So methadone can be used as an adjuvant. That means if you use methadone along with other opioids, for example, if a patient is on 20 milligram of morphine 4 hourly, and this patient has pain relief most of the time, but at night this patient wakes up due to pain and he has to take an SOS dose of morphine. So in this patient, if you start a small dose of methadone, like 2.5 milligram at night, that will give good pain relief. So if you use methadone in small amounts along with other opioids, that can be called as an adjunct. And pain refractory to other opioids. So we saw the patient at first, the patient with Ewing sarcoma who was on previously started on tramadol, then used morphine. There was no pain relief. So you can say the pain is refractory to opioids. So in such patients, And patients who has pain and significant renal impairment need for a long-acting opioid. We know that the duration of action of methadone is 8 to 12 hours. And a high opioid tolerance. We saw for patients who was taking thousands of milligrams of morphine equivalents. So they have opioid tolerance. So in such patients, you can use methadone. And poorly controlled opioid induced adverse effects such as delirium, myoclonus. So if that occurs, methadone can be used. True morphine allergy. So morphine and methadone belongs to different chemical groups. So if the patient has morphine allergy, then you can use methadone. And patients who has complex neuropathic pain. Inappropriate candidates for methadone. If there is a family history of sudden unexplained death, because congenital QT syndrome can run in families. And if you see the ECG of a patient and you see that the corrected QT interval is more than 500 milliseconds, you should not start the patient on methadone. If the patient is unable to give us feedback about pain relief and there is no reliable caregiver to administer methadone, you should not start. And we know that it cannot be used for patients with acute pain because it is going to take 5 to 7 days. So if there is acute pain, we have to use short-acting opioids like morphine to titrate. So how should we monitor the patient? So this should be aligned with goals of care. Suppose the patient is on curative treatment, then we should be very aggressive with monitoring parameters. But if the patient has is only taking comfort care, then the monitoring need not be very aggressive. So what all needs to be done on the baseline? We have to do an ECG to find out the QT interval. Then calcium, potassium, and magnesium, because hypokalemia, hypomagnesemia, hypocalcemia, all these can increase the QT interval. So these are the baseline investigation that can be done. Then after 2 to 4 weeks, you can again do an ECG. Then once the dose of methadone reaches to 30 to 40 milligram, again do one, and then 100 milligram. When methadone reaches 100 milligram, we can again do an ECG to find out the QT interval. And most importantly, we have to wait for 5 to 7 days before you increase the dose of methadone. So this is the methadone preparation available in India. There are both syrup and tablet. Tablet is 5 milligram and syrup 1 ml containing 5 milligram. Okay, now we will move on to methadone conversion. So I shown you a conversion chart at the beginning, but that is not used anymore. We use this method now, which is very simple, and this is the latest method. Okay, so according to this, if the patient is opioid naive, that is, patient is taking less than 60 milligram of oral morphine equivalents per day, then you can start the patient with 2 to 7.5 milligram of methadone per day. But if the patient is taking oral morphine equivalent between 60 to 199 milligram, and if the patient is less than 65 years old, the potency of methadone becomes 10:1. So if the patient is taking 100 milligram of morphine, what would be the equivalent dose of methadone? Patient is taking 100 milligram of morphine. What is the equivalent dose of methadone? Yeah, 10 milligram. Yes. But if the patient is taking more than 200 milligram of oral morphine equivalent per day, or if the patient is more than 65 years old, the conversion ratio is 20:1. Okay. So it is less than 60, 60 to 199, and more than 200 milligram. But suppose the patient is taking 2000 milligram of morphine. What would be the starting dose of methadone? 2000 milligram of morphine. What would be the starting dose? Forty. Dr. Madri says 40 milligram. So whatever be the dose of morphine, you should never start a patient on 40 milligram per day. That is the maximum starting dose. Okay. If you calculate 2000 milligram divided by 20, then that would come to 100 milligram. You should never start patient on 100 milligram. The maximum starting or initiation dose is 40 milligram. So now we will move on to a few patient stories where we can calculate the dose of methadone. So here we have a 37-year-old man who is diagnosed with the carcinoma of the buccal mucosa and another second primary, which is papillary carcinoma of the thyroid, for which he underwent surgery and radiation. And there was recurrence in the node, for which he again underwent surgery. So here you can see this patient. So he is complaining of pain, which is starting inside the left ear and then going to the side of lateral side of forehead and then to submental region. And he described it as a worst imaginable pain, 10 by 10. So what is the type of pain he is experiencing? What type of pain? Neuropathic pain. Yeah. So you can see that pink area, isn't it? That is the mandibular nerve supplied area. That's where the patient is complaining of pain. So that's a neuropathic pain. So because he has neuropathic pain, the treating team they referred the patient to an interventional pain specialist, and they did mandibular nerve block. It was done thrice, but there was no pain relief. And they tried him with injection morphine, thinking that it will give pain relief. But there was some pain relief, but it produced toxicities. And then they stopped the injection morphine and started him on morphine like oral morphine like this 10 milligram, 50 milligram, 10 milligram, and 30 milligram with 10 milligram SOS dose. So only 4 times daily. And you know that it need to be given 5 times. But here they want to get a fine balance of toxicities as well as pain relief. That's why they did like this. But even with this, his pain relief was not satisfactory. He had toxicities of morphine, and he was also tried on various adjuvant analysis. So this was the medication the patient was on: morphine, pantoprazole, ciprofloxacin, escitalopram, serratiopeptidase, diclofenac patch, paracetamol. So suppose you are going to start this patient on methadone. What are the indication to start methadone in this patient? Neuropathic pain, yes. Yes, what else? Toxic symptom, yes. Very good. What else? Too many tablets, toxicities to morphine. Okay. So one is, it is complex neuropathic pain. Then morphine toxicities, not responding to other opioids. So these are the indications to start patient on methadone. So before starting the patient on methadone, what all should we ask? Sorry. Before starting the patient on methadone, yes, a dose of morphine, yes. History of sudden unexplained death in the family, yes, that's very good. Okay, so is there a history of sudden unexplained death in the family? Then we have to also see whether there is any reliable caregiver. Then investigations, ECG and electrolytes, calcium, potassium and magnesium. So do you have any concerns with any of these medications if you are going to start methadone?
Ciprofloxacin.
Yeah, ciprofloxacin, yes. Stop cipro. Okay. Dr. Adra says PPIs. Okay. Any other medications? So what are the medications which can, yeah, SSRI, acetylopram, yes, that's very good. So here we have to see that acetylopram, pantoprazole and ciprofloxacin have interaction where acetylopram and ciprofloxacin is having maximum interaction. Pantoprazole has some interaction, but it is not so significant. Okay, now you are going to start this patient on methadone. Okay, so please calculate the dose of methadone for this patient. So these are the you can see the dose of morphine. Now you can calculate the dose of methadone we need to start on this patient. Okay, 6.5 milligram. Okay, so let's calculate. So this patient is getting how many milligrams of morphine per day? It is 10, 15, 10 and 30. That means total 65 milligram of morphine per day. So oral morphine equivalent is 65 milligram. So what is the equianalgesic conversion dose? Or what is the conversion factor? It is 10:1, isn't it? It's not 20 because if the patient is taking morphine equivalent between 60 to 199 milligram, then the conversion ratio is 10:1. So here it is 65 milligrams. So the conversion would be 1/10. That is 6.5 milligram. So how do you start this 6.5 milligram? So at the beginning, I talked about a 3-day switch method. That is not used now. Okay. And that conversion table is also not used. Now we are completely using this new method. So on the first day itself, you give full dose of methadone. So the 6.5 milligram, you can give it. If you have only tablet, then 2.5 milligram BD, or if you have syrup, give it 3 milligram BD or 2 milligram TID. So we know that with methadone, it will take time to act, at least 5 to 7 days. So till then, you have to continue with morphine. So it is not regular morphine. Instead, it is given. Here the patient was taking 65 milligram of, 65 milligram of methadone. That means, 65 milligram of morphine. So that comes to 10 milligram of morphine every 4 hours, isn't it? So that's why tab morphine 10 milligram Q4H SOS. It is not tab morphine 10 milligram Q4H and SOS. It is Q4H SOS. What does that mean? At 6 o'clock, you will ask the patient, do you have pain? If the patient says, yes, I have pain, you give 10 milligram of morphine along with methadone. And again at 10 o'clock, if the patient has pain, you will give morphine. But patient says, no, I do not have any pain. Don't give morphine. Again at 2 p.m., you will again ask. Patient says, no pain. Don't give morphine. 6 p.m., yes, I have pain. Give morphine. So that's what 10 milligram Q4H SOS means. Okay. So on the first day itself, you give methadone 6.5 milligram along with morphine on 4-hourly SOS dose. So here the patient prescription would be like this. Tab methadone either 2.5 milligram BD, or if you have syrup, methadone 3 milligram BD along with morphine 10 milligram Q4H on SOS basis. Paracetamol can be continued, but we have to stop ciprofloxacin. So instead, you add another antibiotics which can cover that specific infection. Amoxicillin has very less interaction with methadone, so it is safe to use. And this patient was already on, you might have seen the patient was on escitalopram 10 milligram BD. That treating team gave him escitalopram thinking that he has severe depression, because he did not get any pain relief with interventional pain management or injection morphine. So they thought that he is in severe depression. But that was not depression. It is because of his severe pain. So we stopped escitalopram, and this patient was on these medications, and there was little bit of titration needed for methadone, but he had a very good pain relief till his death. Okay, now we will move on to another patient, a 39-year-old woman who has carcinoma of the pancreas with stage 4 disease. She received chemotherapy, but after 5 cycles, it was stopped because the disease was progressive. And she was receiving palliative care. So her main problem was the pain. You can see that the pain starts on left lateral chest going to the back. And her pain, mostly it is 10 by 10, and it comes down to 8 or 7 by 10 when she takes morphine, tramadol, and paracetamol together. So these are the medications she was getting from an treating physician. Tab morphine 20 milligram 6 hourly, injection tramadol 100 milligram IV TID, injection paracetamol, tab carbapenem, tab amitriptyline, and bisacodyl. She had myoclonus with these medications. Okay. So how do you give pain relief for this patient? If you are going to start this patient on methadone, what are the indications to start methadone? Anybody? Toxicity, yes. What else? Toxicity of opioids. Then inadequate pain relief. Okay, one is opioid toxicity. Then it is neuropathic pain, isn't it? It is refractory to other opioids because this patient is on tramadol and morphine, no pain relief. So what are the investigations you are going to do? ECG and electrolytes. Yes, sodium, potassium, and calcium. But you have to think whether you should do it or not, because this patient, she is not on any curative treatment. She is receiving only comfort care. So actually, it is not needed to do ECG or electrolytes. But if you want to make sure, okay, I'm not doing any bad for this patient, maybe you can do an ECG and electrolyte. So what is the, so please calculate the dose of methadone required for this patient. Everybody is so fast. I can see there are many 8 milligrams and 12 milligram also. So let's see. So what is the dose of morphine she is receiving? 20 milligram every 6 hourly. So that means she is getting 80 milligram of morphine. But she is also receiving tramadol. So that's an opioid that you need to convert it into equivalent morphine dosage. Okay. So tramadol, it is 30 milligram. She is receiving 300 milligram of tramadol. That will come to 30 milligram. So 80 plus 30, it is 110 milligram total. So total oral morphine equivalent is 110 milligram. So what is the conversion ratio? If the patient is taking oral morphine equivalent between 60 to 199 milligram, and if the patient is less than 65 years old, conversion ratio is 10:1. So it is 110 divided by 10. It is 11 milligram. Okay. So you can start with tab methadone 5 milligram BD, and what is the dose of morphine you have to give for this patient? You can calculate morphine plus tramadol. That would come to 110 milligram. That means 20 milligram every 4 hourly. So morphine, methadone 5 milligram BD, because we calculated that 11 milligram. So tab morphine, tab methadone 5 milligram BD, or if you want to be perfect, syrup methadone 5.5 milligram, and start morphine 20 milligram Q4H on an SOS basis. Paracetamol can be continued. Amlodipine has some interaction with methadone, but the dose is very small. Either you can stop it or you can continue. And once the patient achieves good pain relief, stop the amitriptyline. And this is another young lady who was finding it very difficult because she was unable to take care of her kids. She was again restricted to her house. And she was telling that she is unable to do anything for for her husband and her kids. So, and because of severe pain, and once we started her on methadone, she had very good pain relief. She had a very good social life. She could attend many functions, including she conducted the first Holy Communion of her kids. So, this methadone gave very good pain relief, and um, she lived more than 2.5 months with good pain relief.
Excuse me, Dr. Sunil.
Yeah.
They just asked in the chat to explain once again the SOS dose. How did you arrive and how did you get that, please? Those are there in the chat box.
Okay, so see here, here the patient is receiving tab morphine 20 milligram Q6 hourly. So total dose would be here it is 80, isn't it? And in addition, she is also receiving tramadol, which you converted into equivalent morphine dose. That would come to 30 milligram because the potency of tramadol is 1 by 10 compared to morphine. So 300 divided by 10, that is 30 milligram. So the total dose of morphine she is taking is 110 milligram. 110 milligram, it would be almost equal to 20 milligram of morphine every 4 hourly. 20 milligram every 4 hourly means 20 into 6. That is 120 milligram, isn't it? So that's why she is given 20 milligram of morphine Q4H on an SOS basis. So if you are asking what is Q4H SOS, that means you give morphine 4 hourly only on SOS basis. You will not give it regularly every 4 hourly. You give it if the patient has pain. Suppose at 6 a.m. if the patient has pain, you have given methadone at 6 a.m. But at 6 a.m. you will ask the patient, do you have pain? Patient says, I have pain. You give 20 milligram of morphine. Then at 10 o'clock you ask the patient again, do you have pain? No, I do not have any pain. Don't give morphine. 2 p.m. Again you ask, patient says, no, I do not have pain. Don't give. 6 p.m. Patient says, no, I do not have pain. Don't give. 10 p.m. patient says, yes, I have pain. Give 20 milligram of morphine. That's what 20 milligram Q4H means. Okay, now we'll move on to another patient. A 40-year-old man who has advanced malignancy of lung with spine metastasis. This is only for you to practice the conversion. Okay. So who has spine metastasis and he had spinal cord compression at T12 level and underwent radiotherapy. After 3 months, patient was complaining of pain, burning pain on both lower limbs, continuous, which is 10 by 10. The patient is already on tab morphine, 40 milligram 4 hourly, no pain relief. So please calculate what is the dose of methadone required for this patient. I can see 24 milligram, 12 milligram, 12 milligram, 12 milligram. Okay. So let's say, so this patient is taking 240 milligram, isn't it? So what is the conversion ratio? If the patient is taking more than 200, more than or equal to 200 milligram of oral morphine equivalent per day, or if the patient is more than 65 years old, conversion ratio is 20:1. So that would be 240 divided by 20, 12 milligram of methadone. So you can start either, if you have only tab methadone, start with tab methadone 5 milligram BD, or if you have syrup, maybe 4 milligram TID, along with tab morphine 40 milligram on a 4-hourly SOS basis. Okay, so I hope that is clear to you, and I would like to end the session by summarizing what we have gone through. So even though in the beginning I told you or talked about Taussade points and interaction with methadone, many medications which can increase the QT interval, um, um, interactions with methadone, either reducing its level or increasing its level. But even though it is like this, what we have to understand is we can safely use methadone in a selected group of patients. So we should not be using methadone for each and every patient who has pain. So we talked about the indications, which are the group of people who would be suitable for starting methadone. So please select the patient according to the indication. And even though there is most of the studies which are conducted with methadone is on patients who are getting oral substitution therapy, and that's where we are getting reports on methadone can produce Taussade points. But we have seen a study in which the MD Anderson Cancer Center did on cancer patients for pain relief, and they found that they didn't find any patient who is getting Taussade points or ventricular fibrillation. So if you use methadone at a lower dose, maybe less than 50 milligram per day, the chances of producing Taussade points and ventricular fibrillation is very, very less. But at the same time, we have to be careful about interactions with other medications that can occur, because most of the medications which we use in palliative care that has interaction with methadone. So whenever we start a patient on methadone, make sure that you have a list of medications that can interact with methadone. Check it, and if there are medication, remove it or substitute with another medicine. So it is always better to use a simple medication regime when the patient is on methadone. Okay, so methadone is a medication which can actually produce good pain relief for many patients. So we know that with the WHO analytic ladder, about 70 to 75% of patients can get pain relief. But methadone, if you use it properly, I think we can give pain relief for many more patients. So thank you. And I can see there
are some questions in the chat box, Sunil.
How frequently methadone should be monitored with ECG and electrolytes? So that depends on the goals of care. If the patient is on getting only comfort care, then ECG and electrolytes are not necessary. But if they are receiving any curative treatment, then I have told you a regime. At the baseline, you have to see the ECG. Then after 2 weeks, then once the methadone dose reaches 30 milligram and then 100 milligram. So these are the points where you have to do an ECG. And if you feel that, okay, there are some medications which you have added can increase the QT interval, then that's another indication to do an ECG. And this is also applicable to electrolytes. What to do if torsades occur? Okay, so I think I'm not sure about. I haven't seen any patient with torsade points. Are there any people from emergency medicine or who has managed torsade points here? Okay. Anyway, you have to maybe I would stop methadone for the time being and start on maybe morphine or fentanyl, which does not have that side effect of reducing torsade points. And maybe later I will take an ECG and see whether what is the QT interval, and then if it is normal, I may start on a low dose of methadone. I would not go for higher doses of methadone, which can produce torsade points.
Hello.
Yes. Dr. Ashish?
Good evening, sir. Oral medicine specialist in Government Dental College, Trivandrum. Hello.
Sorry, I couldn't hear you.
Can you hear me, sir?
Yeah.
Sir, can this methadone will be regularly given in an OP basis in dental colleges, or that need a hospital-based institution?
Okay. So methadone can be stored and dispensed if the institution has an RMI status. RMI means recognized medical institution status. So this is the status given by the state drug controller to procure and dispense essential narcotic drugs, which includes morphine, methadone, fentanyl, codeine, hydrocodone, and oxycodone. But hydrocodone and oxycodone are not available in India, but all the others are available in India. And even with there would be many institutions who have RMA status, but only a few institutions in India are using methadone. That's the fact.
Okay, sir. Thank you.
Thank you very much, Dr. Sunil. Sangeet, can we come out of the screen? I think I've also checked the chat box. There are no more questions specifically to be answered, I think. Anybody wants to ask anything, please go ahead. Otherwise, see, as always, such an extensive session, Dr. Sunil, so that people will have the idea and also the exact method, how it could be used, knowing something which can be very helpful from patient perspective. And as always, we say you will get a full presentation for you all to go through and get all the information, because it might have been plenty of new stuff today, so which will be very useful.
Thank you, ma'am. Thank you, Dr. Sunil Kumar, for the wonderful presentations. Thank you, Dada ma'am, for facilitating the whole sessions. Thank you, participants, for participating in the sessions actively. Thank you. Let's see in the next session. Bye.
Thank you.
Thank you all.